Good morning. It's not afternoon, yes. Dear colleagues, dear guests of Riga, of conference, medical doctors, dietitians, nutritionists, health professionals, minister, representatives, it's very nice to see you here. My name is Andis Brēmanis. I am a medical doctor who is dealing with problems of nutrition, and in my everyday life when I'm consulting my patients, I don't prescribe them drugs like tablets or something like that, but I prescribe them changing lifestyle, changing diet, nutrition, changing their activities, spending spare time, and so on. And therefore, it's very interesting to be here and to hear what's going about these changes in Europe, in the world. And this session will be about young people. Of course, all conferences about young people, yeah? But there will be nutrition for children and young people at schools. And we have 5 persons who will give their talk about that. And as the first one is medical doctor Egita Pole from Latvia. Please take your place. Then will be representative from Estonia, Dr. Tagli Pitsi, please. Then from Hungary, also medical doctor Éva Martos, please, come on. Then Associate Professor Yannis Manios from Greece, please. And Professor Agneta Hornell from Sweden. And the first lecture will be given by Egita Pole. She has medical doctor's degree as well as master's degree in public health administration, master's in public health. And she is working in Ministry of Health of Latvia, and from 2014 has been promoted as the Under-Secretary of State on Health Policy Issues, Public Health, Healthcare and Pharmacy. Please.
Thank you, Chairman. Good morning once again. I'm happy that we have changed gender equality in our session. Before this session, there were a little bit different picture on the stage. Now my duty is more complicated to introduce you what Latvia has done in the area of food policy in more detail. These are the main headings of my presentation: general approach, our legislative basis in the area of nutrition policy, health promotion initiatives, and our challenges in the nearest future. Let me start with telling a little bit about the background for public health policy. As everybody knows, not only Ministry of Health, but other sectors, Ministry of Education and Science, Ministry of Agriculture, non-state actors, international, NGOs, civil society, industry, municipalities, and of course Ministry of Finance should work like gear wheels, close and together. And it is very important that today representatives from different sectors are together, because only investment in health sector, especially in health promotion, will help to develop our country's economy and growth. And it's our task to persuade all sectors and politicians about that. As you can see on the slide, these are main documents emanated from each other. National Development Plan of Latvia, Public Health Strategy, the main document in the health sector, and regulations of the Cabinet of Ministers, which defines precisely our initiatives, and let me tell a few details about each of them. National Development Plan, approved by our Parliament. Human securitability is one of the 3 priorities, and one of the strategic objectives below this is healthy and fit for work. We are aiming at reducing risk factors of chronic diseases and external causes of death. To reach it, we promote healthy nutrition, active lifestyle and mental health, development, children's, youth and popular sports, inclusion of health education in school curricula and others. Our public health strategy is a new improved edition adopted last autumn. The aim shortly is keep, improve and restore health. Two ambitious tasks are to increase by 3 years the healthy life years and to decrease by 11% the potential years of life lost. And here I would like to outline that our public health policy is in line and closely linked with WHO and European Commission documents, what was mentioned earlier today, and all those documents and activities are taken into account in developing our strategies, Health 2020, EU Action Plan on Childhood Obesity, and European Food and Nutrition Action Plan, and others. Coming back to the main issue, let's focus on our nutrition policy. These are main activities which are highlighted in our strategy: to promote healthy nutrition habits in society, to assess the possibility to restrict packaging size for products high in salt, sugar and fat content, to assess the possibility to restrict the marketing of foods high in salt, sugar and fat content in educational institutions and sports halls, sport clubs and others, and to provide state-funded meals for elementary school pupils, including for children suffering from celiac disease. Let's move from strategic framework to practical actions. Regulations, our main regulations in nutrition policy is regulations 172, and the purpose of this regulation is to ensure that the consumption of healthy and balanced nutrition in kindergartens and schools, as well long-term social care and social rehabilitation institutions and hospitals meals. And these regulations define the energy and nutrition norms for kindergartens and schools according to the age or class based on the recommended energy and nutrition intake for Latvian populations. What is more? There is a list of products. I think I skipped one slide. What is more, there is a list of products excluded from the daily menu of kindergartens and schools. Food products deep fried, mechanically separated meat, cream products, mayonnaise, ketchup, tomato sauce for serving, confectionery containing partially hydrogenated vegetable oils. Equally important is the standard. All meals shall be warm and fresh, free from GMO and food additives, and is not allowed reheating. Our approach, not only from a prohibition position, but we have created positive list of allowed products according to nutrition pyramid, of course. We have special requirements for meat products like sausages, smoked and salted meat, processed fishery products. They should contain at least 70% of meat or 60% of fish and do not contain food additives and contain salt less than 1.25 grams per 100 grams of meat. You can see other important regulations, pretty old but revolutionary in those days. These regulations were adopted with the aim to restrict marketing of soft drinks, sweets and salty snacks in education institutions. in Latvia. The regulations were designed to limit the consumption of foods and were not necessary for children's daily consumptions. And it applies to vending machines and school cafeterias. And in that time, it was very revolutionary, and current Minister for Health got international prize for that we succeeded in doing such important things for our pupils. So, what are the results? Dr. Egita Pole from Center for Disease Prevention and Control in the next session will outline detailed survey results, but I just want to pay your attention how significantly the consumption of sugar-sweetened beverages, including soft drink, has decreased, and this process still continues in this year as well. So you see that we succeeded in some results. And of course, regulations without sufficient information mean nothing. Therefore, we, in collaboration with nutrition associations, university and NGOs, dietitians and public health professionals, developed a range of such recommendations on fruit and vegetable intake, daily energy and nutrient intake for home-cooked meals for schools catering providers, and on sufficient physical activity. At present, more attention is focused on information for schools catering providers, because we should help them how to organize meal for pupils to be healthy and for appropriate price, of course. Currently, we have a state-funded lunch for first to third grade pupils, but we are aiming to cover lunch for all pupils and hoping we will get additional money for that from rising taxes on alcohol and cigarettes in the nearest future, and we're hoping in that. At the moment, some municipalities in Latvia provide free school meals as well for other grades, depending on the budget and priorities of the current municipality. I don't stop on this slide. I just want to outline, because our experts mentioned it earlier, that nutrition support programs are available in Latvia, like school milk and school fruit scheme as well. Now I come to my fourth point, health promotion and community involvement, and again, gear wheel is necessary for working together. Center for Disease Prevention and Control, with their promotion activities, involve actively municipalities and experts from different sectors for making health promotion, and created is in that in our real life. At the end of the 2012, the Ministry of Health, together with Center for Disease Prevention and Control, WHO Country Office in Latvia, Latvian Union of Local Governments, and Riga Stradiņš University, started a new initiative, National Health Municipality Network Development, to coordinate activities of WHO Healthy Cities movement and to provide methodological support and to assist in developing health promoting programs for them. At the moment, almost 1/3 of municipalities have joined the network, and in addition, 72% of municipalities have at least one contact person for health promotion and working in their municipality with different health promotion programs. And we still continue this work and involve them actively in the future as well. We, as Ministry of Health, created guidelines for health promotion in municipalities as well. The guidelines provide municipalities with science-based information to implement health promotion and to improve the development of healthy behaviors and lifestyle of the local populations. Of course, main areas: healthy nutrition, physical activities, prevention of additive processes and substances, and family health, and target groups almost all. Healthy Schools Network. The goal of this network is to educate youth about how to promote their health by leading healthy lifestyle and seek to ensure conditions for a healthy environment at school. And we are going to implement health education as a separate module in our educational institutions as well. And that is very important aim for Ministry of Health, and in that area we should work very closely together with Ministry of Education and Science. As my time is limited, I will briefly point out the most important things we are going to do. We have prepared a draft normative act to reduce trans fatty acids in food products. It also includes restriction of the amount of trans fatty acids in food products to 2% of total fat. It's planned that the draft normative act will be adopted in government this year. A draft law for energy drinks includes not only the definition and selling restriction for energy drinks to children, but also includes articles and restriction of advertising and marketing of energy drink to persons who are younger than 18. And we will continue to revise and clarify the nutrition regulation for schools and determine the range of food products that can be distributed in schools. And simultaneously, I would like to outline this to promote healthy choice as the most available and easiest choice for children and youngsters. And it is very important for succeeded work in health promotion and health education area. And at the end, I would like to say that today's rapidly changing and busy world and continuous evaluation of high technologies are some of the contributing factors on the increasingly poor eating and drinking habits and sedentary lifestyle. In the future, we must find innovative and motivating and practical approaches how to support people, especially children and families, in making healthier choices regarding their nutrition and lifestyle. For example, improving health and nutrition information and education, implementing nutrient profiling and labeling, and organizing public awareness campaigns and activities. Intersectoral as well as intergovernmental collaboration is vital here. Thank you.
Thank you. It's nice to hear that things are not going worse but better. Yeah? The usage of soft drinks among young children is going down. In which European country is going so? Is there anyone? Except Latvia. We'll see. Now the representative from Estonia, Dr. Tagli Pitsi, will tell us about the situation in Estonia. Tagli Pitsi has finished Tallinn University of Technology and has got her PhD on nutrition situation on preschool children in Estonia from 1995 to 2004. And now she is also giving lectures in Tallinn University of Technology, and she will give us a lecture today. And the lecture is called School Food Arrangement in Estonia. Please.
Thank you. Dear audience, I'm very happy to be here today and introduce you the Estonian school food system. And thank you, the organizers, for that opportunity. I'm going to give you a short overview of a school system in Estonia, all the requirements for that school food, supportive actions, and also finally some words about concerns or challenges what concerns our school food. In Estonia, people often say that school food is free. Actually, it's not true because school food is only subsidized. Government gives 78 euro cents per lunch, and it covers only the cost of food products to make food dishes. But all the other expenses like electricity, salary, these are not included in this 78 euro cents, and these must be paid by local government or then by parents. The system started 2002, and at first it covered only the elementary school. Now, starting from January 2015, all the classes can have subsidized school lunch. But as you can see, the sum of this subsidy that was at the beginning only 64 cents and now it's 78 cents, it hasn't risen a lot since that time. In some schools, children can also have subsidized breakfast porridge. That's good. And what are the benefits of such kind of arrangement that we can have a proper food instead of all kind of snacks. And also the school food is regulated, its energy content, nutrient content, and also such kind of system gives, at least for those pupils from low-income families, the possibility to get at least once a day proper and warm meal. And also we hope that it can help control the problem of overweight. In addition to this school lunch program, we also have a milk program and fruit program from European Union in our schools as well. Most of the schools are participating in school milk program, and at least 80% of target group is covered with school fruit program. And what comes for menus, then if you are planning a menu at school, you can include these milk and fruits and vegetables into your menu, calculations, nutrients, but you can't include the cost. You have to give 78 cents food, then additional milk or fruit, and you can't include this into that sum. All this school lunch in Estonia is regulated by the national legislation called Health Protection Requirements applicable to catering in preschool child care institutions and schools. And this regulation gives some requirements, for example, for organization of catering at schools, how to provide school food, what must be the energy and nutrient content in school food, how the menus should be prepared, all the documentation, how the nutritional information should be given, and what are the requirements for dining rooms and serving of meals. And every school canteen or caterer should have prepared 10 days menu ahead with all the correct recipes which are given in this menu. The 10 days menu in average should cover then 30 to 35% of recommended daily calories and nutrients. And proteins should contribute 10 to 15%, fats 28.5 to 32.5, and carbohydrates 55 to 60% of energy in all the age groups. As we are now dealing with Estonian nutrition recommendations and we are changing it a little bit, we already know that all these boundaries will be a little bit widened. For example, proteins from 10 to 20, fats from 25 to 35, and carbohydrates from 30 to 60% of energy. And the energy itself has divided into 4 groups depending on the age, starting from around 600 calories per school lunch for elementary school, and then up to 850 calories for classes 10 to 12. And in addition to energy and macronutrients, also fatty acids, fiber, and some vitamins and minerals content is regulated by this regulation. This regulation also says some words about menu and meals overall. For example, that all those meals served in schools must be varied, balanced, healthy and tasty. And here are some examples of menu planning. High-fat fried meals are prohibited. Bread and vegetables should be in the menu every day. Fruits at least 3 times a week. And fish also at least once a week. Some of food products are limited, for example, frankfurters or cooked sausages, and caterers should avoid products containing hydrogenated vegetable fats. Also, some of the water-based flavored drinks, which include colorants, these are not allowed at all, and water should be freely available every day. To support this regulation to caterers, we have done lots of actions. At first, these trainings to school caterers, they take place every year, and these participants can have their information also on CDs to look at them afterwards. Our institute have published a book of sample menus. It includes 40 days for all the age groups and with all the recipes and calculations. Started from 2006, we have been held a contest, the best school canteen. And the aim of this contest is to draw attention to the school food theme, and also to support the caterers and to give them good words about their work, what they are doing. And to support the best school canteen contest, we have also a lunch break contest, which is for pupils, and they can draw pictures on or make videos on school food theme to make this school food more popular amongst the pupils. Also, we have 2 main web pages. The first one is toitumine.ee, which is nutrition, and it gives the general information about nutrition. The second one is a little bit more specific. It's a health information web page, and here you can find all the publications, best practices, trainings, informations, and such kind of information. We have also made posters on school food theme. Here are samples of posters to teenagers. There are compared school lunch and snacks. Also, we have posters to food pyramid or food plate model. One of the most important is probably the dietary analysis program, which is called NutriData, and it consists of 3 parts. The base of this program is National Food Composition Database, which consists around 1,700 food products like milk, carrots, fish, meat, and so on, and also over 1,000 recipes, porridges, soups, and so on. Then this dietary analysis program itself, and also dietary survey database. And using this program is free of charge, so you just have to register it and you can use the program. Unfortunately, it's still only in Estonian, but as this food composition database is available in English and in Russian too, and if you use Google Translator, I know that you can use this program too, because I have taught this program to foreign-speaking language students at school. Here are some pictures about this program. The program allows you to put into program menus using the recipes or food products information from the database, or you can make your own recipes. You can get menu calculations from there and compare them with the results, with the recommendations. Here are some sample menus also for schools and kindergartens and some calculators. Which is like the menu entry picture here. And you can make as much menus as you want. And also in every menu you can have unlimited number of days. But in one day you can have up to 6 meals. And the amounts of eaten food, if you are a caterer, you know exactly how many grams there are in menu, and you can put it in grams. But if you are just an ordinary user and you eat something and you want to analyze your food, then you can have the pictures from the database and choose the right one from there, and it gives you the amount in grams. Here is the sample of recipe making, and it takes into account food losses during the cold preparation and also vitamin loss and water loss during the heating. And here is a sample of results. The results can be driven out in 4 levels. This picture is level 1. It means that you get your results by days, then average, recommendation, and the comparison with the recommendations. The other levels are by meals, by foods. You can see how much energy you got from soup or from your porridge. And the last one is food groups in grams. So you can have an overview how much of vegetables or milk or fish have you eaten in every day and in average. And finally, some concerns about school food in Estonia too. The first is a financial gap between this subsidy by government and by actual cost. Because I know that in some of the schools, at the moment, the summary cost is at least 1.5 euros, and also it might be up to 2 euros, which means that the subsidy from government only gives around half of all the money. No one controls the actual use of money. That's also one of the problems. This subsidy, it's not a regulation, it's only a political agreement, which means that we have now elections and nobody knows what will be after elections. Food sold in cafeteria or via vending machines are not regulated yet, but we hope to do it as we change our regulations after we have changed our nutrition recommendations. And here are some good practices also. For example, self-regulations. I think that in Latvia it is also so that Coca-Cola company says that these sweet sugared beverages are not allowed in school cafeterias. And also Tallinn has prohibited energy drinks in school areas. And in Estonia you can't advertise anything in the school areas. One problem is also food lunch time and duration. It means that in bigger schools in Estonia, the school lunch can be offered 9:45 in the morning. And also the duration is only 15 minutes often. It's not enough to go to the canteen and eat your food properly and then go to the next lesson. And our wish is that this break should be at least 45 minutes long and include also some kind of physical activity then. The rising problem is also so-called thermofood. In Estonia it used to be that so that all the food was made in school kitchens. But now, in order to optimize costs, lots of caterers make the food outside the schools in bigger canteens, and then they bring it in big warm holding vessels to the schools. What comes for nutrients and energy, probably it's not a problem. It's the same if it's made on spot or brought to the school. But the appearance and taste may be the problems. We haven't studied it yet. And finally, this taste and appearance. You can make the school food as well, as recommended, all the nutrients, energy, and so on. But if it's not tasty and it looks grey or something, then nobody wants to eat it. And this is up to caterers, their motivation, their competence, and their goodwill. So, thank you.
Thank you. It is interesting to hear. In Latvia, we have government-sponsored meals for first 3 classes. Yeah, how they manage all the school? That's interesting, of course. Yeah? She said that part is sponsored by government and part by parents or local. Facilities. No, we have to decide how we'll do. Okay. Yeah. Now we'll see a little bit about Hungary. Yeah. Dr. Éva Martos, also medical doctor, is the general director of the National Institute for Food and Nutrition Science with 10 years of experience in public health nutrition, with special focus on childhood obesity. And she will tell us about what's happening in Hungary, nutritional standards for health school meals in Hungary. Please.
Thank you very much. Ladies and gentlemen, first of all, I would like to thank the organizers, the invitation and the opportunity to give you some brief overview in our food policy in Hungary. Today, first, I'm going to show you some results of our national school and nutritional environment surveys, which gave the evidence and paved the way to the public catering regulation. Then I would like to show you the decree on the nutritional regulation, the main elements of the decree itself. In the last years, we have conducted 4 national nutritional environment surveys in schools and in preschools. The methods of those 4 surveys was very, very similar. It consisted of a set of questionnaires for headmasters, food service managers, and parents. Then pictures of meals were also taken, especially for assessing the food waste. Then we analyzed the menu, the food allotment sheet, which means the recipes, and then about 5,000 food chemistry analyses were also measured, including protein, fat, carbohydrate, trans fatty acids, salt, iron, and calcium content of the meal. These are the results of the last survey, showing the provision of minimum 1 portion of food and vegetable daily, and the its distribution by geographical regions. Only 40% of caterers provided minimum 1 portion of fruit and vegetable daily on national average. Based on our laboratory measurements, the salt content of daily menu, lunch and 2 snacks together, was on average 8.6 grams per day, which is about 3 times higher than that of the WHO recommendation for that age group. We evaluated the menus using a special scoring system which based on laboratory measures of salt, fat, and calcium content of daily menus. The higher the score is, the better the menu. Score 3 points means none of the menu got 3 points, which means that they didn't fulfill all the requirements at the same time. Summarizing the results of all these surveys, we can say that daily food and vegetables is not provided by all caterers, salt content of meals is very high, high added sugar content was found in the provided drinks, a dominance of high-fat food products and deep-fried options could be observed, and special dietary needs were not totally covered. It's clear from these surveys that public catering doesn't meet healthy nutritional requirements, and it's also clear that legislative measures with nutritional standards are needed to reduce the significant nutritional risks posed by the present practice. I would like to show you now how finally the decree was born. It was really a very, very long process. Up to now, no legislation existed in Hungary with nutritional standards for public catering. There were recommendations, and new recommendations entered into force, but they were not legislation. At first, there were a joint decree on the conditions of manufacturing catering trade products. Then, in 2011, a recommendation was published for public caterers with nutritional standards issued by the Hungarian Chief Medical Officer's Office, together with the normative decree issued also by the Chief Medical Officer, provided a checklist enabling to monitor the adherence to the recommendations. But it was only a recommendation, and the results, you could see the results of the menu analysis. On the way of the decree, there were several steps. For example, high media coverage of the survey results. Several targeted press conferences were organized during the past 4 years. There was an extensive negotiation and public consultation process involving all relevant stakeholders, caterers, food manufacturers, NGOs, medical associations, parents, municipalities, ministries, and so on. There were some local initiatives with the involvement of local producers, and also conferences, workshops, and roadshows were organized. And the regulation underwent a EU notification procedure. And may I present you some elements of the decree itself. The main elements of the decree that it refers to public catering providers and institutions. It is mainly food-based standards with additional set of some nutrients, salt, sugar, total fat, and calcium. There are some foods and food group which should be provided daily, so which is mandatory to provide them daily, such as milk, dairy products, fruit and vegetables, and whole grain cereals. The decree regulates the number of meals, the portion size, the frequency of certain food groups during 10 catering day, the energy requirement for different age groups, and the variety of hot meals for 20 consecutive catering days. There are regulation and limitations of using certain foods and meals. The public caterers should cover the special dietary needs of each children based on prescription of a doctor. There are obligations to provide information. I mean, there are special labeling rules, for example, salt and allergenic ingredients. And from April 2017, the calculated energy, fat, and so on content of meals should be labeled. There is a rule in the decree on regular qualification of kitchen staff, and also authorities' control is included in the decree. The control should be performed by public health institutes and based on documents and based on laboratory analysis also. It's an example how, for example, the energy requirements is specified by age groups, depending on service type. The standards are designed to act along the nutritional risk factors. Fortunately, one of these was eliminated by the Hungarian trans fat ban. May I mention here that the transient period concerning on Hungarian trans fat ban ended last week. So it means that no food could be purchased if the trans fat content is over the limitation of our Hungarian decree. Various measures aiming to reduce salt intake was implemented in the decree. For example, salt content of each meal has to be indicated on the menu. Salt content of the meal should be gradually decreased to the age-appropriate specified level. No salt or sugar shaker should be placed on tables, otherwise it's mandatory to indicate the excessive salt consumption may lead to cardiovascular disease, obesity, and diabetes. Salt-containing flavoring powders, paste, salt-containing instant soups shall not be used in addition to purposes of improvement of flavoring. Usage of meat products is also restricted. It's also an example from the decree how the amount of salt allowed in the daily menu is regulated, except for the two youngest age groups. 6 years of grace period is given for the gradual reduction of salt content of the meals. As for the measures aiming to reduce sugar intake, there are also several various initiatives in the decree. The milk offered as a drink may not contain any added sugar. No sugar should be added to flavor ready-to-eat dairy products. Sugar concentration of tea is limited. Added sugar intake is limited to an average 8 energy % during the 10-day menu cycles. Sugar shakers are not allowed on the tables. Carbonated or sugar-sweetened soft drinks or syrups shall not be used. Fruit and vegetable drink can be offered maximum 2 to 3 times during the 10 days. Fresh drinking water or mineral water should be offered between meals. Sweets may not be offered as main course for lunch. Being a significant risk factor in the Hungarian diet, it was also important to put some measures aiming to reduce fat intake. Some example of these, that deep fried food should not be used more than once in 10 catering days. Fat intake is limited to 30 energy % in daily average. The following food shall not be used: meat with fat content above 30%, and coconut, nut, and palm oil for frying or cooking. Usage of meat products is also restricted. And for children over 3 years old, low-fat milk shall be provided. Based on our experience, may I share with you some conclusions. One of these, that decision makers need clear and evidence-based messages. Then robust monitoring and evaluation are key. You need to learn different language of different stakeholders, otherwise it's very difficult to convince them on the importance of a policy measures. And media can help to increase demand for a change. Our whole process and regulation is in line with some key areas of EU Action Plan on childhood obesity. We do know that it's one of the several measures which is important tackling childhood obesity, but we strongly hope that it will be really an effective measure and it will lead to the halt of the obesity prevalence, childhood obesity prevalence in Hungary, and the consequent cardiovascular risk factors and other non-communicable diseases of the Hungarian population. Many thanks for the attention.
Thank you. It was very interesting report. And the main phrase that I remember, Hungarian trans fat ban. I think it can have a good sound. Latvian trans fat ban also, yeah? That's going on to happen, yeah? Okay. We are hoping that we can also be colleagues in this front. Okay, thank you. And the next one speaker will be from Greece, Associate Professor Yannis Manios. His research interests are focused in the development of and implementation of interventions aiming to prevent or treat obesity and obesity-related diseases by promoting a healthy and active lifestyle throughout lifespan. He is a great researcher. He has 300 research papers. He has 7 awards from national or international organizations. He will be telling interesting things, because the heading of the lecture is the ToyBox-study, a European kindergarten-based, family-involved intervention aiming to prevent obesity in early childhood. Please.
Thank you. Good afternoon, ladies and gentlemen. I would like to thank the organizing committee for giving me the chance to present to you the ToyBox-study. However, the first part of my presentation will focus on some brief literature review on school-based interventions. School seems to be the ideal place to implement health promotion initiatives. It gives contact to large cohorts, large contact time to the pupils. It has already developed infrastructure and human resources. When they properly train, they can deliver the intervention and hopefully have meaningful results. However, the question is, do these school-based interventions work? And more specifically, in the area of obesity, can we actually prevent obesity through school-based intervention programs? In this review from Flynn et al., we can see that after they examined 147 studies, they came to a conclusive results. In other words, they were questioning whether actually these studies, this kind of intervention, are effective. But if we look closer to those 147 studies, we'll see that the majority of those studies are of low or medium methodological quality. And if we look even closer and isolate only those 21 studies with high methodological quality, we can see that out of 11, it's 11 because I have excluded the clinical studies on the right end. So out of 11 school-based and community-based interventions, 6 managed to improve body composition indices, and 8 out of 11 improved dietary habits and physical activity. So this is good news. So interventional schools can be effective, as long as they are of high methodological quality. But what actually means high methodological quality? In my understanding, and actually I think that we share the same view with quite a lot of colleagues working in the area of health promotion in the school and community setting, these interventions has to be rooted in behavior change theory and not being too general. So don't focus on the overall Mediterranean diet pyramid, for example. Identify specific behaviors that seems to be related to obesity or the understudy issue you're focusing on, and their determinants, and determinants means knowledge, beliefs, attitudes, perceptions people have in mind. Take into account stakeholders' view, contextual factors and policy framework. Whatever you do has to be within the legal framework and the policy framework in each country. Target schools and home, social and physical environment. That means not only change the school and home environment, but try also to engage teachers and parents because they are part of the social environment for the kids. Have a minimum duration of 1 academic year. Don't do something just for a few weeks or just an event. Do something constantly, continuously for a year, every day. And be low in cost, use available human resources and infrastructures, and perform process evaluation, which means from period to period or periodically evaluate whether actually the intervention you design has been implemented as it was actually designed. This concept was already incorporated in the ToyBox study, which started in early 2010. The aim of the ToyBox study, which is a kindergarten-based intervention involving parents, is to prevent early childhood obesity, targeting kids at the age of 3.5 to 5.5 years old, and of course their families too. By creating a supportive social and physical environment at kindergartens and at home to facilitate the desired behaviors, using a low cost and therefore a potentially cost-effective approach. Low cost means whatever we had to do, whatever we did, has to rely on available human resources and infrastructure. So the study started in April 2010. There were 12 academic institutes involved, 2 health promotion organizations, and 1 SME. And the actual data and the intervention took place in these 6 cities, in these 6 countries. The first 2 years were dedicated to develop the intervention for the ToyBox project. And the intervention was based on systematic reviews and secondary analysis, but also focus groups. Focus groups with parents in all 6 countries, focus group with teachers in all 6 countries, in order to identify which are the most common issues or the most common behaviors we need to tackle in all these 6 countries. So we came up with those 4 behaviors: water consumption, healthy snacking, physical activity, and sedentary behaviors. So our aim was to create an environment that will support regular water consumption by the kids, a healthy snacking on a daily basis, physical activity in and out of school, not necessarily sports, but any kind of activity, active commuting, walking to school, and sedentary breaking behaviors. Don't allow kids to sit for a prolonged time, either watching TV or computer games. Just give them an opportunity to have a break and stand up. Using the intervention mapping table, we develop our intervention material, leaflets for the parents and the teachers, and we train the teachers to create a kindergarten environment that will host, that will facilitate those desired behaviors. We train the teachers to implement the desired behaviors in the school setting. We train the teachers to conduct the interactive activities in order to promote and advertise those behaviors to kids. And also we target and involve parents via newsletter, tipcasts, and posters on a monthly basis. So this is an example for the water consumption. We change the kindergarten environment, you can see before and after, by creating a water station. So all classes had to have a water station. So water has to be there available for every child, and every child should have her own glass or bottle. Perform the behavior. That means the teachers had to have a break every 30 or 40 minutes roughly to have some water with the kids, The teacher has to be an active role model herself, so he should participate in this behavior as well. Regarding healthy snacking, we had to establish a healthy snacks choices during school hours, either by encouraging parents to give to their kids healthy options, or by encouraging the local municipality, if they were providing the food in the daycare centers and the kindergarten, to have this option for the kids. And have it on a daily basis, not just periodically, on a daily basis. Regarding physical activity, we reform the classes so as if the weather conditions did not allow any physical activity outside, we could have physical activity inside, in the class. And the physical activities we were promoting were not sports related, were not skills related, were just any kind of funny exercise, any kind of funny movements with no winners and therefore no losers, because we didn't want to discourage the less gifted kids or the obese kids, which are primarily in need of these initiatives. And that has to be done, that was taking place at least 2 times per week. Regarding sedentary breaking behaviors, on the left, you can see in some cases we try to achieve that either by removing the chairs, so some of the handicraft activities kids were doing, they could be doing by standing, or have a break, ideally combining with drinking water, so kids had to stand up every 30 to 40 minutes to have some water and stretch the legs and the hands just to have some sedentary breaking activities. We had some complaints by the teachers. They thought, oh, we will lose focus of the kids. The kids have to be focused on doing the work. But this is not true. If we have kids for a prolonged time sitting, forced to be sitting, they lose their attention. So it's good to give them a break. It helps them again to go back to focus, to do other activities in the class after these breaks. And of course, we had to promote those behaviors, and that was done by our role model, the kangaroo, and stories and experiments implemented in the school class. And of course, parents had to be also involved, actually actively involved in the program. So they were receiving newsletter and tip cards relating to those behaviors, and as you can see, every month we were giving out, actually the teachers were giving to the parents leaflets and tip cards on water consumption, on physical activity, on snacking, sedentary behaviors, and so on. And as you can see in the poster, the black and white drawing, kids were given these posters and they were asked to color them, and then they were happy to go back at home and stick them on the wall. So we were trying to do the best we can to ensure that parents will get the message and read the sign like do not eat in front of screen or limit screen viewing activities. Make your own experiences. So we were doing the best we could to inform parents, to get them involved and transfer the message to them. So some results from this program. The data we'll present to you are coming from these 6 countries, and for more than 5,500 children and parents successfully completed the 1-year, 12-month intervention. As you can see regarding overweight and obesity, the blue column is the intervention group and the green column is the control group. And on the left is the baseline data and on the right is the follow-up data. There was no significant change, both for the intervention and control group, on the prevalence of overweight obesity throughout these 12 months. And to be honest, we were not expecting to see any changes in body measures at this age group with this approach within 12 months. But now we're working on this data because interpreting BMI changes is a bit tricky for this age, because you can see that this is the age on the bottom. Between the age of 3 and the age of 6, BMI is going down. So the steepest, and this is on the upper percentiles, the steepest decline of BMI is for obese kids. So you might think, oh, they're losing BMI, BMI is going down, but they're actually the obese kids, while there's more or less a plateau for the thin and normal weight kids on the bottom. So interpreting this data has to be done carefully, and now we're working on that. But what about the behaviors we promoted? So as you can see, we managed to significantly increased children's water consumption from 2.6 to 2.8 portions per day, but a significant increase was also observed for the control group. However, as you can see with the interaction effect on the right corner, that difference was significantly higher for the intervention group, indicating that our intervention was successful in this perspective. Regarding parents serving water to their children during meals, there was a significant increase from 82% to 26.5% for the intervention parents, no significant change for the control group, and the interaction effect was significantly higher again for our intervention. Children's sweet consumption significantly decreased for the intervention group. A borderline, I would say, non-significant change was observed for the control group, but the overall, again, interaction effect indicates that the significant decrease we observed for the intervention group is significant and positive. Parents' sweet consumption was also significantly decreased for the intervention group, while no change from baseline to follow-up in the green bars were observed for the control parents. And regarding physical activity and sedentary behaviors, we can see that the parents, the percentage of parents doing some kind of physical activity more than 3 times per week increased from baseline to follow-up for the intervention group, while there was no significant change for the control group, and this effect on the intervention group is significant. And regarding children's screen time, the data here is split on weekdays on the left and weekend days on the right. And it's interesting to see that screen time increased from the age of 4, which is baseline, to the age of 5, which is follow-up, during weekdays, and that increase was significant, unfortunately, for both intervention and control kids. However, the interaction effect on the top left was significant, indicate that the increase was significantly smaller for the intervention kids. Regarding weekends, the same pattern. Kids in both intervention and control group increase, instead of decreasing, increase their time devoting on screen time, PC and video games. But again, this interaction effect, 0.032, was significant, indicate that the increase in screen time was significantly smaller for the intervention group. So I think the way we interpret this is good, because we managed to slow the increase of PC and video games time, but it's interesting to see that the most time devoted on this kind of activities is during the weekends, not the weekdays. For physical activity, unfortunately, is exactly the opposite. So weekdays, physical activity during weekdays on the left is higher, and weekends is lower for the kids of this age. And the same pattern again. There was no change on the physical activity during weekdays, so we did not manage to increase physical activity as it was measured by pedometers. So every single child was wearing a pedometer, and this is the percentage of children spending or doing more than 10,000 steps per day. So in the case, I will explain this to you, in the case of the baseline data, the blue bar indicates that 62% of the kids were achieving this threshold, and in the follow-up, 1 year later, 62.4%, the same percentage, is again achieving this threshold. But interestingly and disappointingly, during weekends, we saw a significant decline for both intervention and control group. So what we actually see is that after 1 year, from the age of 4 to the age of 5, kids during weekends spend significantly, or a larger proportion of kids meet the recommendations. So this is going down already at the age of 4, from the age of 4 to the age of 5. So we did fail to increase physical activity during weekends, although that could be one of our goals. However, why did we fail? And this is the price we had to pay for delivering intervention with a common approach throughout all European countries. We failed because delivering one approach for all cannot accommodate differences between cities like Ghent or Athens, or even differences within the same city. This is a high SES area in Athens with plenty of swimming pool and tennis courts and plenty of space for a kindergarten school. And it's a low, medium size with much less space for the kids in the kindergarten area, but probably higher opportunity for active commuting activities in the neighborhood. So overall, we managed, and it seems that we were successful in improving children's PC video games, children's water consumption, children's and parents' food consumption, parents' vigorous activity. However, the data presented to you is mean values. They're coming from the intervention schools in all 6 countries, Germany, Belgium, Bulgaria, Greece, Spain. However, the question is not to look at the mean values. The question we need to address is, have we managed to benefit those primarily in the need of the intervention? And this is what we're currently working on, and I can give you an example of what I mean. If we look back in 2012, before our intervention, and we look on the baseline data, you see the prevalence of obesity, and that was shown by other colleagues this morning. The prevalence of obesity in the south of Europe at the age of 3.5 to 4-year-olds is already much higher, more than 20% in Greece, compared to that observed in Belgium and Germany, which is in Germany is less than 10%. So we see in the south of Europe higher prevalence of obesity, in Bulgaria and Poland somewhere in the middle, but we heard that the trend is rising very fast, and Belgium and Germany is the lowest percentages. And this prevalence of obesity can be explained by the percentage, this is the column, the red columns, the percentage of kids spending more than 2 hours per day on screen time, and as you can see it's much higher in Greece, much lower in Germany on the other end, but also by the physical activity. And the kids meeting the recommended levels of 10,000 steps per day is much higher in Germany, 46.2%, compared to the south of Europe, Spain and Greece, which is about 30%. And this, what color is it? You call it purple? Purple color? No, the purple, this color? Purple, yeah. This one? Purple. This is purple, okay. This is watching TV during lunch. And you can see a similar pattern. Much smaller percentage of kids in Germany and Belgium are watching TV during lunch, much higher in Greece and Spain, and the light blue columns indicate the percentage of children watching TV during dinner, which is much higher in Bulgaria and Spain. Actually, in Bulgaria, we realized that parents perceive TV as a very good educational tool, and they actually encourage their kids to watch TV. Actually, about 70% of the kids have a TV set in their rooms in Bulgaria. So we see different trends of behaviors, different prevalence of obesity, and I'm sure you can understand that if we look within each country, we will see huge differences within regions and socioeconomic groups within each country. And we need to understand, I think this chaotic slide gives a very clear picture that nothing can be the same everywhere. So we have to look on specific subgroups. And I just give an example to indicate that. If we look on the prevalence of obesity in the south of Europe, in the low socioeconomic group compared to the medium and high socioeconomic group, you see that there's a significantly higher prevalence of obesity among low socioeconomic group kids in Spain and Greece. 9.3% are obese compared to 7.2%, and this is significant difference already at the age of 4. So we were talking about health inequalities and social inequalities. That means we do have them, and they're present already at the age of preschool kids. So the question is, do we have to implement behavioral change or intervention to all countries, to all socioeconomic groups? If we do that, do we actually increase or tend to increase social inequalities and health inequalities even further? Or do we have to focus on these specific subpopulation groups on primary needs for these interventions? And I will finish with these thoughts, which are the main conclusions from our study. So we observe large differences on the prevalence of obesity throughout Europe and within each country and between sex groups in each country. So that means, in my understanding, we have to focus in regions and socioeconomic groups with the highest prevalence of obesity. We observe very different behaviors and determinants and physical environment throughout European Union countries and within countries and in different socioeconomic groups within each country. And we believe that we have to develop and implement school-based family-involved interventions from now on in the future, tailor-made to the local needs of each group or municipality in each country. So one size does not fit all. Within each school, we've seen children with the highest prevalence of obesity, and within the same class, we saw kids be normal weight. So maybe we need to identify these children and families at high risk within the given class and invite those families, the adults, parents and grandparents, to attend additional sessions in municipality settings outside the school delivered by healthcare professionals. So school-based initiatives are good. Teachers can do a very good job, but they're not specialized to treat obesity or medical diseases. So maybe for some families, it's very important they have additional counseling sessions that those parents can attend in a very discreet manner outside the school in municipality setting. And all that can be done by using available facilities. And when I'm saying facilities, I'm not only referring to schools, I'm referring to parks, to cycling ways, to parks, personnel available in the schools, but also in the municipality health centers, and use also mobile technologies to further lower the cost of these interventions. This concept I just described to you was put together in application for Horizon 2020, and it was successful. So we just a month ago, January 2015, we're starting a new program in Europe to test this hypothesis. So our program, Field for Diabetes, the initial stands for Families Across Europe Following Healthy Lifestyle for Diabetes Prevention, is aiming, and I'm finishing, is aiming to deliver similar things to what we discussed in the ToyBox project, and this is targeting all families component, but we put one more component at the end, local municipality initiatives. So we will try to get the local municipalities to be more actively involved, so in creating and supporting environment around school in neighborhoods to promote these behaviors, and the targeting higher risk families component, and for those kids and families which seems that they need additional help and they need to follow some structured lifestyle counseling sessions, we will offer those to them for free and follow them up for 2 years. And as I said before, we need to focus on vulnerable groups, and that's why we selected Hungary and Bulgaria, which are low to medium income countries in Europe. We selected Greece and Spain to tackle vulnerable groups in 2 countries under economic crisis in Europe, and Belgium and Finland to tackle vulnerable groups within high-income countries in Europe. If you need more information on the ToyBox study or the material which is available for free, just visit our website. And if you need more information on the Field for Diabetes, we don't have a website yet, but please email to me for any request. Thank you for your attention.
Thank you. That was very interesting, because as we often talk, a child who is coming to school and has bad eating habits, it's too late to work with him, because eating habits are developing at the age of, I think, 1.5 or 2, when the child is taken off the breast and he sits right down at the table together with his parents. And that's what you are doing. Yes, it's okay. Thank you. And now we have the last lecture in this session. It will be represented by Professor Agneta Hörnell. She is professor in food and nutrition at Umeå University in Sweden. She is also a registered dietitian and a member of various teams, and her interest started in breastfeeding and infant feeding, and now has expanded and includes different aspects of food and health in both children and adults. And the theme of lecture is a special catering at schools for children with celiac disease, food allergies, lactose intolerance, etc., related challenges and the role of the dietitian. Please.
Thank you. I would like to thank the organizers for giving me the opportunity to speak at this important meeting. As several persons before me have said, children spend a large proportion of their daily life in school, making this not only a place for learning, but also an important place for food intake. For children with special dietary requirements, what they eat is of extra importance, and the question is whether school meals can protect these vulnerable children. As I will show in my presentation, I believe it is a matter of professionalism, communication and trust. And dietitians have an important role in this, but how well it works varies around Europe. I am here as a representative for EFAD, the European Federation for the Associations of Dietitians, which was established in 1978. Since then, EFAD has grown a lot and now represents over 30,000 dietitians in 26 countries, approximately half of the dietetic workforce in Europe. Dietitians have the knowledge of human nutrition and dietetics that make them able to work with dietary modifications to optimize health. There are three main types of dietitians: clinical, public health, community, and administrative dietitians. During my presentation, I will talk a little bit more about them and their roles in ensuring safe school meals for vulnerable groups. There is not enough dietitians in Europe to cover all needs for both clinical and public health primary care, as well as for research and advice to industry. There is also another profession with competence in the field of nutrition, and they are the nutritionists. However, worldwide, they see themselves primarily as scientists undertaking research, while dietitians work like healthcare practitioners, only within strict ethical principles, undertaking continuous professional development to remain competent. We need nutritional scientists to do research, including surveillance and evaluations, but we need dietitians to work at primary, secondary, and tertiary healthcare levels, and with the civil society to implement change. Before I continue with the school meals and the role of dietitians, I will give you a short description of two types of adverse food reactions, their causes and treatment, so you get a better understanding of the context. As you can see on these pictures, there are many kinds of adverse food reactions. Some are immune-mediated and some are not. I will use celiac disease as one example of an immune-mediated food intolerance for several reasons. It is a common disease affecting about 1% of most populations, and it has profound effects on the food requirements for the individual. And also, my group has been carrying out research on children and adolescents with celiac disease for many years now. Lactose intolerance is an example of a non-immune-mediated food intolerance, and it affects about 5 to 90% of adults in different populations. Some more details about celiac disease. Here you can see a normal gut. It has long villi, helping to absorb the nutrients. When someone with celiac disease eats foods containing wheat, rye, or barley, the villi is damaged, totally or partially, by a protein called gluten in these grains. And the only way to treat celiac disease is to remove the gluten. But as long as the person with celiac disease keeps to a strict diet, their gut is fine, and they are as healthy as anyone else. Removing gluten may sound as an easy solution, but it has profound effects on the diet of most individuals. Especially wheat, but also rye and barley, are very common ingredients in many of the staple foods in most European countries. If we look at this traditional food pyramid, a very large proportion of the base has to be removed or replaced by gluten-free alternatives. And there are also many foods from other levels, like the top one, where cakes and buns has to be deleted, and many things of those things are eaten for celebration and other kinds of festivities. There are also some foods that might not be as obvious: fish fingers, meat stews thickened with wheat flour, etc., that has to be excluded. In addition, the gluten-free special products are usually much more expensive than regular products. Many European countries give celiac patients gluten-free foods on prescription, like they do to children in Sweden. Some countries have tax deductions for the extra cost, like they do in Ireland, and others give a monthly stipend, like they do in Italy. However, this is to the individual, not to caterers providing food to the schools. As I said before, lactose intolerance is not an immune-mediated intolerance. Instead, the intolerance is due to a lack of an enzyme involved in the digestion of lactose, which is found in milk and most milk products. Some common clinical features are failure to thrive, poor growth or stunting, or poor performance. As with celiac disease, management is about removing or replacing the offending foods. The prevalence varies a lot on a global scale, 5% in Northern Europe and as many as 90% of adult population in Africa and Asia. And this difference is important, as lactose intolerance therefore can affect migrants much more frequently than indigenous populations in most European countries. When it comes to the focus of my talk, celiac disease, food allergies, lactose intolerance and related challenges, the three types of dietitians all have important roles. First, the clinical dietitian. They are part of the diagnostic team. They do clinical monitoring, and they also prescribe diets on a one-to-one basis. The public health dietitians, they work primarily with policies, food labeling, nutrition and health education, and evaluation and surveillance. With regard to policies, the EU mapping on national school food policies has been mentioned earlier today, and this mapping showed that all EU 28 countries plus Norway and Switzerland, they have school food policies in place. And there is an almost even split between the countries where they use voluntary guidelines and those that have obligatory standards. There are three primary aims that are common in most member states: to improve child nutrition, to teach healthy diet and lifestyle habits, and to reduce or prevent childhood obesity. However, the degree of implementation and effectiveness in achieving these stated objectives is unclear. And only 2/3 of the policies mention training of school catering staff. The provision of school meals in Europe varies a lot, both between countries and often also between schools within a country. There are various types of meal services. There are school kitchens, there are catering services, tuck shops and vending machines. There are also various types of economical arrangements. There are free meals for all in a few countries, Sweden, Finland and Estonia. And there are arrangements where parents have to pay either for the whole meal or for parts of it, or where children bring their own food or they go home to eat. And in some countries, meals are provided for some at a lowered cost or free of charge, usually for the poorer groups. In addition, the food realities in schools are much more complex than this, and it does not only include school lunch. There are also the schemes for school fruit and vegetables and milk. There are school gardens, and there are also cooking classes. And regardless of how the food is being provided, it should be nutritious, and the whole meal, including the physical surrounding and social arena, needs to be appealing to ensure that children actually eat the food. Because there's one thing what we plan and another thing what children actually eat. As I said before, all European countries have school food policies in place, but not all policies consider evaluation. Less than 2/3 define outcome measures. An evaluation is an important part of school meal catering. If you don't evaluate, how do you know you're doing the right thing? The third type of dietitians, the administrative dietitians, they work primarily with food service management. And as I said before, all dietitians have the knowledge of human nutrition, dietetics and food that make them able to work with dietary modification to optimize health. And the administrative dietitians, they work primarily with food service management. And with regard to school meals, they have a key position when it comes to providing healthy school meals for all, reducing inequalities and improving nutritional health in Europe. There are many reasons for individuals to have special dietary requirements. It can be that the individual experiences some kind of adverse food reactions, as I mentioned in the beginning of my talk, but there are also religious, cultural, or ethical constraints. And these special dietary requirements are mentioned by the school food policies in many countries. And since December last year, life became a little easier for those with food intolerances, because then the EU Food Information for Consumer Regulation came into force, listing 14 different allergens that need to be identified if they are used as ingredients in a dish. And from December 2016, information on these have to be available in the school kitchens for every item on the menu that contains any of the 14 allergens as ingredients, and gluten is one of these allergens. And this is an example of the labeling of gluten from Latvia. As mentioned earlier, Sweden is one of the 3 countries with free school meals for all school children, and it has a long history of it. And it includes preschool to high school, so virtually all children between 1 and 18 years of age. And here are some pictures from a typical canteen in a Swedish school. Usually the children eat together at tables where also the teachers take part as a pedagogic meal. And the children used to serve themselves. And most schools have a varied vegetable bar with an assortment of vegetables that the children can take, and there are also usually cooked vegetables that they serve sort of like on the left-hand side you take. The national guidelines are available from the Swedish National Food Administration, and there the following is stated. To give opportunities for healthy food habits to all pupils, it is important to ensure that also those with special dietary needs are served food that meets nutritional recommendations. Unfortunately, this is not always happening, as I will show you shortly. I will use some data from a survey by the organization Swedish School Meals Supporters as example. And the participation rate in these surveys is quite high. Last year, 89% of the 290 municipalities in Sweden participated in the survey, and the responsible person in the municipality answered the questions. The proportion of municipalities with an administrative dietitian or a food manager planning the meals in the schools have increased during the last years and are now about 90%. The level of training varies a bit, and in this slide you can see the level of training among the school meal staff in the participating municipalities. The dark blue lines are for the elementary school ages 7 to 16, and the light blue are the preschool ages. In about half of the schools, at least 75% of the staff have some kind of training. But it's interesting to know that 11% of those answering the survey did not know the competence level of the staff in elementary school, and 22% did not know the level of competence among staff catering for preschool children. My group have published research showing that adolescents with celiac disease experience many practical and social dilemmas in daily life directly linked to the need for a gluten-free diet. Practical dilemmas were related to, for example, poor availability of gluten-free foods, especially outside the home. Social dilemmas were related to the risk of social devaluation when their special dietary needs made them visible to others. For instance, due to having to ask questions about the content of the food or their food looking different. And cheating with the gluten-free diet could be a socially more comfortable solution than to follow the diet. So we wanted to know how it was at school, whether they were supposed to be able to get food easily that fitted their dietary needs. And I will present some preliminary data from focus groups with adolescents aged 15 to 18 years of age. The study covers all food aspects of school, including home and consumer studies, but today I will focus on aspects related to the provision of safe food in the school meal setting. The participating adolescents were getting close to the end of their school years, and they all had experience from several schools. And I will use some citations to illustrate some of the results. All the adolescents told stories about when their eating possibilities in school had been compromised. Sometimes there were no gluten-free food at all, or it was gone before they came. It was pasta bolognese, and I thought, where is my pasta? I went in and asked, and it took 10 minutes or so. Then they came back and said, we haven't got any pasta for you. Then I got 2 potatoes with the minced meat sauce. Okay? Sometimes the gluten-free dish looked very different, which could cause discomfort and insecurity. Sometimes when I take my food, it's as if everyone stares at me. What kind of strange and disgusting food are you eating? Most likely they don't think so, but that's how it feels. If the wrong food was served at lunch, or when a complete gluten-free dish was apparently not available at lunch, the adolescents had to choose between eating the normal dish and therefore maybe harming the villi in their gut, or eating available natural gluten-free components only, risking a nutritionally incomplete meal, or skip the meal altogether. Too often, whether the provision of food in the schools were safe, that is gluten-free or not, depended on the individuals working in the kitchen. The knowledge and interest among the canteen staff was one important factor. They said, yes, I think this goes well, but for me, I think it's just not good enough. It was often difficult for the celiac adolescents to judge whether the provided meal was safe or not. All the adolescents could tell stories about occasions when mistakes had been made and they had been given the wrong information. Sometimes they do a mistake. Then they come running in the school canteen after I have eaten half the portion and say, I made a mistake. Each time after such an experience, you don't trust them. It will be like, are you sure I can eat this? The adolescents felt that part of the problem was when none of the staff felt responsible and no one kept attention or were engaged. It depends entirely on your school and the kitchen staff there. Some do not understand at all, but others have been great. Children spend a large proportion of their daily life in schools, and school lunches have a very significant role in the health of children. It's important for learning healthy habits, and the well-balanced school meal has been shown to improve both concentration in class and educational outcomes, as well as decreasing the number of sick days. Given that, what is being done by governments and others to ensure all children have a balanced and enjoyable lunch? The European Food and Nutrition Action Plan has been adopted by the European region to support initiatives to improve the health of European citizens, including actions for governments to promote better health for children through school meals. Policies focusing on school meals should be part of a whole school approach to health promotion. And implementing nutrition standards for the school lunches will lead to improved nutritional intake. Dietitians are a key health workforce to support policy development and implementation, but many European countries lack a fully functioning profession, and this can be a limiting factor, especially when advising specialist provision for those children who cannot eat all types of food. This slide shows the number of EFA dietitians in Latvia, Britain, Sweden, and the Netherlands. As you can see, the ratio of dietitians to the total population varies quite a lot. In summary, EU action plans and government policies can support improved school lunches and child nutrition, and local school food policies will lead to action. Improved knowledge of allergens and labeling will support safe food choices, and the workforce prepared to implement safe and healthy food and nutrition for all children will lead to success. So, thank you.
Thank you. As we saw, one thing is when we are talking less sugar, less salt, more fiber, but there are part of children who have serious health problems, and that's another thing. Yeah? It was a very nice lecture, thank you. The best thing is that we are managed in time. Bad thing is we had 20 minutes for discussion, but these 20 minutes are gone. We have 2 minutes. Maybe somebody has very hot question. Is there anybody with hot question? No. Fool. Then it's time for lunch. You must be back at 3 o'clock p.m. Bad thing is that it's not time for siesta. Maybe during session 3 you'll manage. I don't know. Let's see what happens afterwards. Have a good appetite. thank you for all of you, of course. Thank you.